Hello everybody, this is Dr. Day. The video aims to provide study tips for exam 3, and in this recording we will discuss a few highlights and clarify key concepts for your neurological content. The video is not a comprehensive lecture on the content material, and your major source of study for this week are your textbook, Fitzgerald Amplify, and other resources within the course. And of course, this video review is optional. Here's your topical list for this week, and you also received this in the announcements at the start of week 7. These are the topics that you are responsible for knowing on the test, and I will also send out your week 3 study guide spreadsheet so that you can populate that as you study. Bell's palsy is an idiopathic cranial nerve 7 palsy that causes lower facial paralysis and typically occurs on one side of the face. It's self-limiting, and complete recovery usually occurs in around 80 to 85% of patients within a few weeks or months. The symptoms of paralysis can start slowly and worsen over the next 48 hours, but patients usually seek medical care fairly quickly because these symptoms are alarming to them. The cause of Bell's palsy is most likely viral, typically from herpes simplex virus infection, and estimated around 40,000 people in the US are affected by Bell's palsy each year. Males and females are affected equally, and it's more common in people between the ages of 16 and 45. It's not a disease of the young and old. And higher incidence is seen in people with diabetes, hypertension, trauma, toxin exposure, Lyme disease, HIV, pregnancy, and those with upper respiratory ailments. Recovery from facial paralysis usually occurs over 3 to 6 months, and people at risk for incomplete recovery are those older than 55 or who have hypertension, experience pain other than ear pain, and have complete facial paralysis or have changes in lacrimation. So those are kind of the risk factors for people that may have a prolonged effect. So the clinical presentation, as we said, it's cranial nerve 7, which is the facial nerve, is the main nerve innervating the muscles of the facial expression. And for this reason, you'll see the patients are unable to raise their eyebrow, wrinkle their forehead, close their eyelid, whistle, smile, pronounce words where they have to purse their lips and suck. And they'll be positive for cheek puff when talking, tongue deviation, and maybe fluid leaking from one side of the mouth. So they will be able to swallow, they just, their lips won't close, and so the liquid will leak out the side of their mouth like they've had anesthesia. Closely inspect the patient's ears and palate to assess for herpes zoster lesions that would indicate something called Ramsay-Hunt syndrome, which is herpes zoster affecting the facial and auditory nerves, causing facial palsy and cutaneous herpes zoster lesion of the external ear, palate, and maybe even the tympanic membrane. Associated symptoms include tinnitus, vertigo, and deafness. The Diagnostic and Statistical Manual of Mental Disorders defines dementia as a significant cognitive impairment that represents a significant decline from a previous level of functioning. Cognitive impairment refers to a decline in at least one of the following cognitive domains: language, executive function, complex attention, perceptual motor function, social cognition, learning, and memory. The disturbance must interfere with independence in everyday activities and not be better explained by another neurocognitive disorder. You can see in the table 8.1 from your textbook, it lists various types of dementia, neurodegenerative diseases, types of dementia, and non-neurodegenerative disease types of dementia. Dementia can also be reversible or irreversible. There's some forms of dementia that are reversible, and you can see a list of these in your textbook. But some of the reversible causes include delirium, B12 deficiency, subdural hematoma, and thyroid disease. The irreversible dementias include Alzheimer's, vascular dementia, Parkinson disease, and others listed in the table 8.1. And the most common type of dementia in adults is Alzheimer's disease, comprising 60 to 80% of cases. So the risk factors for developing Alzheimer's type dementia is Alzheimer's dementia is higher in people of color than in whites. Additional risk factors that have been identified include lower educational and occupational levels, family history, history of head injury, Down syndrome, and vascular disease. The clinical presentation of dementia, these patients often don't report a cognitive decline themselves. Rather, a spouse or relative typically will bring it up to the practitioner. The cognitive impairment in dementia must be a change from a previous baseline. Insidious in onset, progressive, not due to an alternate medical problem, and severe enough to impact independence of daily functioning. So there's quite a few criteria in that manual, in the DSM manual, that define the diagnostic criteria for Alzheimer's. It includes, of course, a history. You should talk about any kind of sedating medications, sleep disorders, screening for depression. All of these can contribute to some of the symptoms that we may also see in Alzheimer's. So a complete physical exam, including a neurological exam, and what you're doing is you're aiming to rule out anything else. It's sort of like at this point, a diagnosis of exclusion. You're trying to rule out anything physical, and in a mini mental state examination, which I'm sure y'all are familiar with, the MMSE, and those are some of the tests that you can do, and they're quick and easy to do in the office. If these fail, then you may, if the patient doesn't do as well as expected, they score low on these tests, then you'll want a more detailed testing and refer to a neuropsychologist, those people that specializes in older people and dementia. Laboratory tests should be obtained to screen for hypothyroidism and B12 deficiency. Other tests can be considered on a case-by-case, including electrolytes, calcium level, liver function test for syphilis, HIV. Brain imaging with CT or MRI should also be done to rule out any reversible causes of dementia and diagnosing the underlying etiology of the dementia. So I actually had a patient in the hospital when I was an RN, and he had come in and he had sudden onset of dementia. And that was what the chart said, sudden onset of dementia. And he was in the ICU, and he had a living will or advance directive that said, do not feed, no tube feedings. And this man was he was so cognitively impaired that he couldn't eat. And they were not doing even fluid resuscitation at one point, no IVs. But in long story short, this man ended up having a UTI, and his family declined all treatment because he had dementia and he had a living will, and everyone was kind of going along with this. And I found it very alarming, and I brought it up to the ethics committee. And in any event, they got him an NG tube, got him feeding him, and they treated him for an infection. And a year later, he was out mowing his lawn. So the moral of the story is that this is not sudden. This isn't sudden onset. Dementia happens over a period of time, and if it is sudden onset, you need to think about something else that's going on, and not necessarily dementia, more like delirium maybe. There are two types of strokes, hemorrhagic and ischemic. Approximately 80% of strokes are ischemic and 20% are hemorrhagic. Ischemic stroke is also called an ischemic cerebral infarct. It is caused by decreased blood flow to and subsequent tissue necrosis of a localized part of the brain. Etiologies include embolism, thrombosis, and hypoperfusion. A trans-ischemic attack, or TIA, is a temporary episode of focal cerebral ischemia that resolves spontaneously and does not leave permanent damage. People who have a TIA are at higher risk for future stroke. As we talked about in dementia, delirium is one of your differentials when you have a patient with confusion. Delirium is sometimes called an acute confusional state. And we need to distinguish between delirium and dementia when we're evaluating confusion in older adults. Patients with a history of dementia have a higher incidence of delirium, whereas delirium may also exist as a state by itself without any evidence of dementia. You can see in table 6.1 in your book, the differences that you'll see on clinical presentation between delirium and dementia. So for your clinical practice and for testing purposes, be sure to review this chart. The two do share common characteristics. And once the cause of delirium is corrected, the patient should return to their previous state of cognitive functioning. Pay special attention to the differences between delirium and dementia when it comes to the sleep-wake cycle disturbances, which is a hallmark symptom to differentiate between delirium and dementia. For primary headache evaluation and management, I'm not going to go through all of the signs and symptoms and diagnostic criteria for each type of headache because you have other resources that are excellent, including the textbook, Fitzgerald, and Dr. Glass's lecture. The most common type of headaches are tension headaches, and 80 to 90% of people experience a tension headache at some point in their life. But it's good to understand the differences in the type of headaches and be able to diagnose them because, of course, diagnosis leads to appropriate interventions. Be sure to watch Fitzgerald Headache Management presentation, again, focusing on slides 1 through 4. Pay special attention to prescribing abortive agents, especially to those people with cardiovascular disease. On slide 4, during the last half of the slide presentation, the focus is on pregnancy and nursing mothers, which is not included on exam 3, but you will need this for your clinical practice. On slide 5, beginning at 1 minute, at 1:10:32, the Choose Wisely discussion is excellent and worth listening to again along with slide 6. The lecture includes excellent headache evaluation and diagnosis information, the use of triptans, including caution with the use of other medications, and the risk for serotonin syndrome. For medications, focus mainly on the information for your textbook as far as the medications that will be covered on exam 3. And you can see from the table 6.2 from the textbook, there's some key safety information highlighted on the table. So be sure and just kind of review this again and go through that section in your textbook. Fitzgerald offers a lot of good information for practice, and it'll be very helpful as a reference for you. But the information for the exam comes mostly from your textbook. There are a number of etiologies for a secondary headache. Secondary headaches usually present as an abrupt single episode or new onset in older age individuals. Of course, it's essential that primary care providers understand the differences between primary and secondary headache and to be able to effectively and safely help your patients. Most of the problems that are external to the central nervous system are covered in other units within this course. Your textbook has a similar table to the table that's posted here, and you can review the information without spending a ton of time with the management of each individual problem as an etiology for secondary headache. Your focus should be on the primary care perspective with the recognition of serious health events with appropriate workup, transfer, and referral as indicated. Think about each of these etiologies for a secondary headache and think about how you would respond and differentiate between a primary and secondary headache through a review of system and physical exam. Most of the headache red flags, and that's the identification of a serious problem, have to do with secondary headaches or things that can be, life-threatening or that we need to act on now. That's why they call them a red flag. And you've seen that SNOOP mnemonic, and there's variations of it with, a bunch of P's and a bunch of O's and things like that. And I've just posted one of the samples here of the SNP. It's the SNP4 mnemonic. And some of those red flags are a progressive, a fundamental change in headache that worsens over time. Patient says, this is the worst headache of my life. New onset of headaches before age 5 or after 50. Persistent headache precipitated by Valsalva maneuver, exertion, or sex. And I did have a patient, both that had this persistent headache precipitated by exertion, which was running, and it didn't just stop when it was over, and also by sex. Fever, acute glaucoma, hypertension, myalgias, weight loss, or scalp tenderness. These are all concerns. Neurological signs, you can review those as part of your studies. And headache with syncope or seizures are red flags. Older adults have fewer headaches overall, and when an older person presents with a new onset headache, suspicion should be high for underlying systemic disease such as temporal arteritis or intracranial lesion. These headaches require immediate medical attention. Temporal arteritis or giant cell arteritis or GCA affects men and women equally and occurs predominantly in adults older than age 60. Its incidence increases with age, and it's rare in younger people. Associated symptoms included scalp pain, jaw claudication, and polymyalgia rheumatica. Other symptoms are local swelling, tenderness, and pulselessness of the temporal artery. Systemic symptoms of fever, anorexia, weight loss, and chills, and some systemic markers of inflammation are also present. With GCA, the ESR, the erythrocyte sedimentation rate, may be highly elevated from 50 to 100. The CRP, C-reactive protein, may also be elevated. However, levels of both ESR and CRP may be normal and should not be used alone to rule out GCA. And you can see in the picture that temporal artery, it's very prominent and tortuous. You can feel it. It would be firm. GCA must be carefully considered in a middle-aged or older patient who presents with a new unexplained headache, and surgical referral may be necessary for temporal artery biopsy and definitive diagnosis, or possible use of chronic steroid therapy. But this is a problem where you're going to want to make a phone call. You're going to want to get other people involved in this specialty and other providers. Older adults generally have fewer headaches, and when an older person presents to you with a new onset headache, you should be highly suspicious for an underlying systemic disease, such as temporal arteritis or intracranial lesion. These headaches require immediate medical attention. Temporal arteritis or giant cell arteritis, GCA, affects both men and women equally and occurs predominantly in adults over the age of 60. It's rare in younger people. Associated symptoms include scalp pain, jaw claudication, and concurrent polymyalgia rheumatica. Other symptoms you might see are local swelling, tenderness, and pulselessness of the temporal artery. You can see that in that picture. That's a very good example of what you might see in somebody with giant cell arteritis or temporal arteritis. Systemic symptoms might be fever, anorexia, weight loss, chills, and systemic inflammation markers may be present, but they're not diagnostic. The SED rate, the ESR, may be extremely elevated, greater than 50, and the CRP, C-reactive protein, may also be elevated. But this isn't, you don't have to have an elevated inflammatory marker for this to be present. So you don't want, it's not 100% diagnostic. Uh, GCA must be carefully considered in middle-aged or older people that present with a new and unexplained headache. Surgical referral may be necessary for temporal artery biopsy and definitive diagnosis, or the use of chronic steroid therapy that they may need to be on over a period of time. In any event, this is a referral. This is a consult with somebody in a specialty position, and even if you have a collaborating physician, go ahead and bring them in on this and share the joy. It's always good to consult and to collaborate on these serious problems. Always have on your differential list herpes zoster as an etiology for headache. Herpes zoster rarely occurs in individuals younger than 30. It's more severe in individuals older than 50 and may occur in up to 50% of your patients older than 60 years old. Initially, the patient with herpes zoster may present with a headache or unexplained pain. The pain is described as constant or intermittent and may have a tingling or stabbing quality. The pain usually starts 48 to 72 hours before the eruption of any type of skin rash. And note that lesions located inside the mouth or the external ear opening are often associated with unilateral facial weakness, vertigo, and hearing loss, and is referred to as Ramsay-Hunt syndrome. Acute neuritis along the path of the rash dermatome can occur. The picture shown are zoster lesions that are drying up. And the classic eruption description for a herpes zoster rash is vesicles appearing on an erythematous base. You will see this on your boards, and this is how you'll describe it in the medical record. And vesicles appearing on an erythematous base is classic herpes infection. The rash usually begins as erythema and then evolves into papular lesions and vesicles. The vesicles rupture, releasing infectious fluid, and then form scabs. Occasionally, the vesicles coalesce to form bullae. The skin lesions usually continue to develop for 3 to 5 days, and the entire disease course usually lasts 10 to 15 days. In some individuals, the skin lesions can persist up to 30 days or longer, and pain can last longer and become chronic. Usually, the history and physical examination are all that are needed to make a definitive diagnosis, and because the characteristic appearance and distribution of lesions, along with the history, establish the diagnosis. If the diagnosis is questionable, a PCR assay along with antibody titer can be done. For management, manage the healing vesicles to prevent infection, attend to pain relief, and prescribe antiviral therapy. Early intervention in the treatment of herpes zosters produces the best results, and antiviral therapy should be started within 72 hours of symptom onset. Valacyclovir or Valtrex is most commonly prescribed because of the ease of dosing. Systemic corticosteroids are ineffective and are not recommended for the treatment of uncomplicated herpes zoster. So if you just have a patient in the office, you diagnose herpes zoster, don't give them corticosteroids. And later on, if there's complications, then a decision can be made then. Patients with ophthalmic herpes affecting the first branch of the trigeminal nerve should be referred to an ophthalmologist because this can cause blindness. Meningitis is an inflammation of the meningeal membranes of the brain, and it's most often caused by infection. Acute bacterial meningitis is a purulent infection of the subarachnoid space. Bacteria enter the host via the nasopharynx, where they can enter the underlying blood vessels. Risks for meningitis include infectious exposure, recent infectious symptoms, evidence of immunocompromise, underlying systemic disorders, and a travel history. Signs and symptoms include fever, photophobia, headache, neck pain and stiffness, and you'll hear this described as nuchal rigidity, and I'm sure you had this in your RN program. These symptoms can be accompanied by vomiting, lethargy, confusion, seizures, or coma. And hopefully these patients are already in the ER if they have that severity of symptoms, and that's usually where they'll go because of concerns. Other signs can include fever, tachycardia, tachypnea, eye pain with movement, positive Brodzinski's and Koenig signs, and in severe cases, severe back spasm can cause arching. Bacterial meningitis can cause hydrocephalus, altered level of consciousness, and seizures, as we talked about. Cranial nerve dysfunction can occur, leading to diplopia, deafness, facial weakness, and pupillary abnormalities. Cerebral spinal fluid analysis will be completed, and it's good to review the table in your text for this exam, which includes some details about diagnostic CSF. Of course, CSF is not done in primary care. The primary offending bacteria include S. pneumoniae and meningitis, and both of which are encapsulated and protected in the bloodstream by their capsules. Other organisms include Listeria and gram-negative bacilli. When a patient complains of something like dizziness or lightheadedness, it's really important to clarify what this means. Common descriptions of lightheadedness can be things like, I feel like I'm going to faint, I feel my heart flutter. You can also ask, does it feel like the lights are dimming or lights out? These are things that I've heard in the past to describe lightheadedness. Lightheadedness can be caused by circulation issues, hypoglycemia, anemia, etc. For vertigo or dizziness, I ask, do you mean the room spinning? And I'll usually hold up my finger and make a spinning motion like a tornado. If they say no, then I ask them about lightheadedness. Vertigo has etiologies including vestibular, labyrinthitis, stroke, tumors, Meniere's disease. There's a nice chart in your text on that's figure 6.2, and that's what's on this slide. You can review this for more detailed information. Meniere's disease is a disorder of the inner ear that causes severe vertigo, tinnitus, hearing loss, and a feeling of fullness in the ear. You may hear complaints of congestion in the ear, and this goes back to our previous discussion of what congestion means to your patient with regard to symptoms. You always need to clarify that word. Meniere's disease usually affects only one side, but in about up to 25% of the people, both ears are involved. In Meniere's vertigo can occur suddenly or after a period of tinnitus or difficulty hearing. Some people have single attacks separated by long periods of time, while others may have attacks that are close together over several days. Some people have vertigo so extreme that they lose their balance and fall, vomit, and these episodes are called drop attacks. Excuse me. Meniere's disease is rare in children younger than 18, but can develop at any age, but it's more likely to occur in adults between 40 and 60 years of age. Approximately 615,000 individuals in the United States have Meniere's disease, and about 45,000 new cases are diagnosed each year, according to the American Hearing Research Foundation. For management of Meniere's, antihistamines and anticholinergic medications such as meclizine or Antivert or promethazine are the most commonly prescribed medications for acute vertigo. Patients are instructed to take the medication as needed on a short-term basis. Of course, we all know that anticholinergics are on the Beers list for older people, so the shortest period of time and the least effective dose. Antiemetics can be considered when nausea and vomiting are severe, and these are usually compazine or suppositories. Vestibular rehabilitation exercises can help the patients with symptoms of vertigo. Multiple sclerosis, or MS, is a chronic and potentially disabling disease of the CNS that begins most commonly in young adulthood. Common symptoms include visual changes, weakness and numbness, and loss of balance. It causes demyelination of the brain and spinal cord, which can be seen on MRI. MS is thought to be a disorder of the T and B lymphocytes, in which the body's immune system attacks the myelin coating of the nerves in the central nervous systems. MS is most commonly diagnosed between the ages of 20 and 50 years, with the median onset at age 30. The first symptoms of the disease usually occur between 20 and 40 years. And if the disease is diagnosed after 50, it tends to be more progressive and worse. The disease affects 2 to 3 times more women than men. It is common among white people and people of Northern and Central European descent, with people of Asian and African descent at lower risk. About 450,000 people in the United States are diagnosed with MS. The most common presenting symptoms in MS include fatigue, leg weakness, bladder and bowel dysfunction, gait issues, paresthesias, and optic issues. Symptoms may begin to manifest over a period of hours to days. This can come on very quickly. And the disease is fraught with exacerbations and remissions, so they get better and worse. The subjective complaint at first presentation or at presentation depends on the location of the active lesion. Optic neuritis causes unilateral blurred vision, dulling of colors, or sometimes even blindness in the eye. Transverse myelitis, spinal cord inflammation, causes bilateral weakness, numbness, spasticity, and bladder dysfunction. Brainstem lesions can cause double vision, tremor, ataxia, and dizziness. When a patient presents with symptoms that may be from MS, it's important to ask about previous neurological symptoms that may have come and gone, transient neurological symptoms. The diagnosis of MS requires demonstrating multiple lesions over time affecting different areas of the central nervous system. On the eyes should be examined. If there's optic neuritis, you may see an afferent pupillary defect. You may also see trigeminal neuralgia. In advanced MS, spasticity may cause pain, interfere with sleep, or prevent movement, and pain syndromes are common. There may be a sensory impairment with complaints of tingling or numbness in the face, limbs, or trunk. And there may be a sensation of electricity down the back after passive or active neck flexion. And this is called Lermite sign. You can review the various physical examinations that are indicated, but they're individualized according to the patient's signs and symptoms. So I don't think it'll get super specific as far as which examinations are to do, but it will be based on the patient's symptoms. They also might experience mood and cognitive changes. And attention deficit may present in early MS even before the onset of physical symptoms. For diagnosis of multiple sclerosis, CSF aspiration is sometimes indicated. MRI is a sensitive, objective measure of plaques and is used to diagnose multiple sclerosis and to measure outcomes of the patients. Periodic recording of the volume and number of lesions detected in the brain by MRI can assist the clinician in monitoring the extent of the disease. These people are normally managed by specialty care, a neurologist. But you may end up with these patients in your practice and they don't have funding, whatever it is, you may end up managing or helping to manage these patients as part of the team. Symptomatic management and therapy are important in MS. So we're helping them to feel better, right? Managing the symptoms. Spasms, they can have antispasmodics, implanted baclofen pump. For tremors, Inderal and Klonopin. Neuropathic pain, your typical gabapentin, duloxetine, and the antidepressants, duloxetine and nortriptyline. And patients will also lots of them seek out alternative medicine, complementary and alternative medicine, about 70% of people, because of the progressive and debilitating nature of the disease. Some of the things you'll find them using is acupuncture, hypnotherapy, biofeedback, Tai Chi, therapeutic touch, Reiki, bioelectromagnetic therapy, and chiropractor therapy. It's important to know how they're treating this, and to understand some of these practices and these CAM therapies, and just know that most of them need further research and into their effectiveness and value for treating multiple sclerosis. Parkinson's disease is a chronic, progressive, degenerative disorder of the basal ganglia in the central nervous system. The disease usually begins insidiously and eventually leads to disability. Parkinson's is the second most common neurodegenerative disorder in older adults after Alzheimer's. It typically affects people in the middle to later life, with a mean age of onset at 57 years. The incidence is slightly higher in males, and people of all ethnic groups are equally affected. Age is the greatest risk factor for Parkinson's, and an estimated 2% of the population will be affected by the age of 80. Idiopathic Parkinson's is the most common cause of Parkinson's and make up 78% of those affected by the disease. 15% of patients have a family history of Parkinson's, and the morbidity and mortality rate for Parkinson's is higher than the general population. An estimated 9% of patients will become disabled or die within 1 to 5 years of diagnosis, 21% within 6 to 10 years, and almost 38% in 11 to 15 years. So it's a serious problem. One of the more common causes of Parkinsonism is the Wilson's disease, which causes an abnormal accumulation of copper. Your textbook highlights Wilson's disease in children in a little box, and we're not studying children in this course, but just know it's there. The major manifestation of Parkinson's is tremor at rest. The tremor may be the reason the patient or family first seeks care, and it's usually the first symptom of Parkinson in 70% of the patients at initial diagnosis. The classic resting tremor of Parkinson's is a low frequency tremor in the distal parts of the body that appears in the extremities, and it's at rest. It can mimic the motion of rolling an object between the thumb and forefingers, and this is why it's called pill rolling. I've only seen that in a few patients. I generally just see the tremor. Rigidity is a state of increased muscle tone felt when the clinician passively moves the patient's neck and limbs when they are completely relaxed. Akinesia or bradykinesia is the inability or difficulty to initiate voluntary movement, appearing as freezing, mid-action, delayed responses, or a general lack of spontaneous motion. often seen in Parkinson's disease due to dopamine deficiency. And we saw this on some of the news reports of our politicians, this freezing action. And postural disturbances form the P of the trap. You can see it on the little insert there, tremor, rigidity, echinacea, and postural disturbances. That's your mnemonic for the cardinal symptoms of Parkinson's. In addition to the motor symptoms of tremor, slowness, and stiffness, a variety of non-motor symptoms are common, including cognitive decline, anxiety, depression, orthostatic hypotension, bladder issues, fatigue, drooling, constipation. It affects the whole body. And in the later stages, it can affect even the breathing. Since tremor is a common complaint and a major symptom in Parkinson's disease, please be sure to review the tremor diagnostic algorithm in Chapter 6. You will find this helpful during various tests that you take, and especially find it helpful in clinical practice. For management of Parkinson's disease, the principle of management is to control symptoms, because there is no drug or surgical approach that has been found to prevent the progression of the disease. Each patient has a unique set of signs and symptoms. As we saw in the previous slide, there's just a multitude of symptoms that can occur in addition to the TRAP symptoms. In early Parkinson's, when the symptoms are mild and not disrupting daily activity, treatment can be deferred. But when the Parkinson's symptoms begin to interfere with activities, medication treatment should be initiated. So the decision when to initiate symptomatic treatment should be individualized. Numerous medications are available. Levodopa is the most effective medication for Parkinson's, and typically motor symptoms improve when treated with it. It's the first drug that we put them on. Over time, patients can develop motor symptoms. Their motor symptoms can worsen, and this can affect quality of life, and then combination therapy can be started to help with these other problems, these other symptoms. Once levodopa therapy is started, the rule of thumb is to administer the lowest dosage that controls the symptoms. And an adequate trial of a reasonably high dose should be tried before deciding a patient doesn't respond to levodopa. With more advanced disease, patients also experience an on-off phenomenon. And sometimes it helps, sometimes it doesn't. And after 2 to 5 years of treatment, more than 50% of patients experience fluctuations in their response with dyskinesia at peak doses. So their dyskinesia fluctuates even at high doses, their response to the medication. And recurrence of the symptoms can pop up as the medication wears off and the next dose is due. So the decision to refer to a specialist should be made based on the practitioner's knowledge level and comfort with treating Parkinson's and on the severity of symptoms. As the disease progresses, it may become necessary to refer the patient to a movement disorder neurologist or a neurosurgeon to consider surgical treatment such as deep brain stimulation. The term seizure refers to a sudden transient symptom or change in behavior caused by abnormal electrical activity within the brain. Seizures can be provoked by an underlying medical condition or unprovoked. A provoked seizure may never recur nor require treatment beyond treating the underlying medical conditions. Causes of provoked seizures, we all know febrile related seizure in infancy also trauma, hypoglycemia, hyponatremia, hypocalcemia, substance use disorder, and withdrawal from alcohol. Provoked seizures are most often generalized tonic-clonic seizures. Epilepsy, by definition, is a condition in which an individual is predisposed to seizures and has two or more unprovoked seizures during their lifetime. Seizure disorders referred to in this slide include the diagnosis of epilepsy. And we all know status epilepticus is defined as a seizure lasting longer than 30 minutes or multiple seizures without a return to baseline in a 30-minute period. And this is a medical emergency. Seizures are common and affect about 8 to 10% people during their lifetime. Each year, about 300,000 people seek medical attention because of first-time seizures, and the majority of patients are younger than age 5 when they present with a febrile seizure. Epilepsy is among the most common neurological condition affecting more than 2.5 million people in the United States. And each year, 50 to 100,000 individuals in the United States are diagnosed with epilepsy. Epilepsy may start at any age, but the incidence is bimodal, and that means the highest frequency is in the young and people over the age of 65. In most newly diagnosed cases, no specific cause is identified. Many factors have been implicated in the etiology of seizure disorders, such as head trauma, infections, stroke, things like that. Also, it's a higher risk in children who have intellectually challenged, have a brain injury, genetic disorders, things like that. Seizure disorders can also occur in families. The parent, sibling, and offspring of a patient with a seizure disorder are more likely than the general population to have a seizure as a result of both genetic and environmental causes. You can see on this slide there's a chart for seizure disorder classification. Now there's also a table in your book that has similar information in it. I found this one online because I thought it was a little bit easier to see the classifications and their descriptions. Excuse me. Focal onset seizures are those in which the first clinical and EEG changes of the seizure are limited to one part of the cerebral hemisphere. A focused seizure can lie in any area of the cerebral cortex, so patients' seizures can be very different depending on the area of the brain affected. The focal onset seizure is further classified on whether consciousness is impaired during the attack and whether there is motor involvement at onset, such as repetitive and rhythmic jerking of one limb. Focal onset seizures may progress to generalized seizure, and then they're called focal to bilateral tonic-clonic seizure. When you hear the type of seizure, I like this new classification system because when you hear the name of the seizure or the type of seizure, it actually tells you a little bit about what the patient experiences during a seizure. For example, focal impaired awareness seizures, in that type of seizure, they're focal, a small area, a focal area, and they have impaired awareness. And so they'll have this focal EEG changes plus impaired awareness. And these are the most common type of seizures in adult epilepsy. Typically, patients will appear awake, but they are not aware of their surroundings and don't respond appropriately to others. And they may have chewing, lip smacking, repeating words, or gestures. And on the other hand, during focal aware seizures, they are aware of their surroundings and they have their senses about them, such as smell and all that. And this used to be called simple partial seizures. And so you can see the difference between focal aware seizure versus simple partial seizures. It's a little bit, those are the same thing, just a different naming convention. And it's obvious that during this type of seizure, there is awareness is preserved. Generalized onset seizure are those that begin with generalized abnormal electrical activity in the brain. Examples include tonic-clonic, absence, myoclonic, tonic, and atonic seizures. Generalized onset seizures are often associated with childhood onset of generalized epilepsy syndromes. Both hemispheres are involved, so consciousness is typically transiently impaired. Motor manifestations are bilateral, and the EEG will show bilateral and widespread seizure activity in both hemispheres. An absent seizure is a non-motor seizure that causes a sudden interruption of ongoing activities, typically with a blank stare. If the patient is speaking, speech will be slowed or interrupted. If the patient is walking, they will stand transfixed. If eating, the food will be stopped halfway to the mouth. The attack typically lasts a few seconds. So you should review these naming conventions in the textbook and understand them as best you can, and then you can find just more information in the textbook with descriptions. The evaluation of new onset seizure disorders are most often completed in acute care because patients have gone to the hospital or they've been referred to specialists by a primary care provider. If the decision to treat a seizure disorder has been made, then the type of medication prescribed depends on the type of seizure. In my practice, I have not started a patient on treatment for a seizure disorder. I've always I've had lots of patients with seizure disorders on medications, but I have never been the first line treatment for any patient with a seizure disorder. These disorders should be managed by a trained, experienced provider, and consultation with a neurologist is recommended. In your text, Table 7.1 provides a list of the most commonly prescribed medication used to treat various types of seizures. I'm sure that you're familiar with many of these from your RN practice and have seen them in your practicums. In primary care, you will definitely have a role in seizure medication management. In Table 7.1 from your text, I've highlighted the therapeutic ranges for several of the medications. You don't generally need to know these numbers, but it is possible you might see them on the boards or in other exams. When a medication has a narrow therapeutic range, be sure that you are monitoring drug levels periodically and per the guidelines. You will also want to monitor for adverse effects of the medications and for breakthrough seizures. In 2008, the U.S. Food and Drug Administration issued a warning about the possible increase of suicidality linked with anti-epileptic drugs. For this reason, it's important to monitor your patients on these medications for changes in behavior, depression, and suicidal thoughts. And I did long-term care, and there were patients with seizure disorders or epilepsy that were on these medications and were no longer seeing a neurologist. And I would prescribe the medications and monitor their drug levels and for adverse effects. So this has been a large body of knowledge that you're expected to know for exam 3. It's a good thing that you have a little break over the holidays to maybe do some more reading. And in addition, be sure and review your health assessment neurological section. You'll want to look at some of review the cranial nerves and some of those tests that test those cranial nerves, and other tests to assess cerebellar and other functions. Just kind of read through there, familiarize yourself with the names of some of those tests and what you're looking for when you're doing the test. So let me know if you have any questions or concerns. Thank you.